Dobar dan, dragi moji. Nama je stigla naša nedelja, sa njom je stiglo i samo naše vreme kada vi i ja zajedno zdravo mislimo. I ja sam nedavno čitala jedan tekst u New York Timesu i znatno manje postoji interesovanje za organ koji ima višestruke funkcije i bez koga normalan život apsolutno ne bi bio moguć, a to je pankreas. I šta više, u jednoj veoma zanimljivoj anketi koja je sprovedena u Americi, većina ljudi čak nije ni znala gde se pankreas tačno nalazi, kao ni koja bi to bila njegova bar okvirna funkcija. Sad ja želim danas sa vama to da podelim i reći ću vam da je pankreas veoma važan organ. Zašto? S jedne strane, on je endokrina žlezda. Kada mi kažemo da je endokrina žlezda, znači da hormone proizvodi i oslobađa direktno u krv i to su dva važna hormona, insulin i glukagon. Verujem da znate, dakle to su nama dva najvažnija hormona koji učestvuju u regulaciji nivoa šećera u krvi. Međutim, s druge strane, pankreas je i egzokrina žlezda. Šta to znači? To znači da proizvodi i luči pankreasne sokove i oslobađa ih izvan krvi u susedne organe. Sad, pankreas proizvodi pankreasni sok koji je pun enzima, izlučuje ga u lumen 12-palačnog creva, odnosno duodenuma, i na taj način omogućava varenje ugljenih hidrata, masti i proteina. I ako sada pogledamo kako bismo dali odgovor na to pitanje gde se nalazi pankreas, ja slobodno mogu da vam kažem da je on sakriven iza trbušne duplje, a ispred kičmenog stuba. Dakle, ovo je pankreas. Sad ja ću vas podsjetiti na jednu vrlo jednostavnu interpretaciju pankreasa. Ako želite brzo da steknete predstavu gde se tačno nalazi pankreas i kako on izgleda, najjednostavnije je da uzmete vašu desnu šaku, spojite palac i mali prst, skupite prste i postavite šaku ovde u centar gornjeg dela trbuha. Figurativno možemo da kažemo da ova moja šaka liči na pankreas i da se nalazi tu gde je on. Dakle, iza trbušnog zida, a ispred kičme. Sad, baš kao što je ovako koren moje šake širi, pa se lagano šaka sužava, tako otprilike izgleda pankreas. Dakle, ovaj koren šake, ovaj širi deo odgovarao bi glavi pankreasa, ovaj deo koji se sužava telu pankreasa i prsti bi odgovarali repu pankreasa. I ja verujem da ste vi čuli za termin pankreatitis. Kada mi kažemo pankreatitis, mislimo na zapaljenje pankreasa. Tu postoje akutni i hronični pankreatitis, međutim, oni predstavljaju dva potpuno različita oboljenja u svakom smislu. Sad, pored tog akutnog i hroničnog pankreatitisa, kada pričamo o bolestima pankreasa, postoje oboljenje koje, nažalost, duži vremenski period ostane neprimećeno. Često se otkriva u odmakloj fazi bolesti kada su nama terapijske mogućnosti smanjene, a to jeste karcinom pankreasa. I negde lečenje bolesti pankreasa u medicini uvek predstavlja izazov. Mi ćemo danas upravo pričati o tome. Pričat ćemo o najsavremenijim metodama lečenja bolesti pankreasa i ja sam zaista imala zadovoljstvo da na ovu temu razgovaram sa jednim od najcitiranijih autora kada su bolesti pankreasa u pitanju, profesorom doktorom Guralponur Džejhanom, i mi sada krećemo u našu vizitu.
Chronic pancreatitis is a disease which you cannot get rid of.
Kako si?
Najteže pitanje za početak, da?
You are not only a surgeon in chronic pancreatitis, you are a tailor.
Kako čovek da uspe da ostane dosledan sebi?
Nemoj pisati tekstove za narodnjake.
Is chronic pancreatitis the risk factor for developing a pancreatic cancer?
Sometimes surgeons use this as some kind of threat.
Kako stojiš sa vožnjom?
Pa znaš kako kažu, ima budala u saobraćaju. To kad kažu misle na mene.
Dear Professor, thank you so much for your time, and I'm really honored to have the opportunity to talk to you, knowing all the things that you do in the field of pancreatic disease research. I would like to begin with pancreatitis. So let's explain to our audience the difference between the acute and chronic pancreatitis.
First of all, thank you. It's for me a very big pleasure to have with you that interview. And I think the question is already good because acute and chronic pancreatitis is completely different. They have all in the end pancreatitis, but it's like an egg and a watermelon. It's completely different diseases. The acute phase we have more in patients with gallbladder stone diseases or excessive once alcohol or fatty consumption where you can get pancreatitis. But chronic pancreatitis is something which is taking a lot of time to develop. And there are several reasons to have this. One of the most, unfortunately, effective one is the etiology of alcohol consumption. So it's about 80%, 75 to 80% of all the patients who develop chronic pancreatitis do drink much alcohol, but there are also a lot of people who just once drink alcohol, let's say not in a big way, but still develop chronic pancreatitis. So it does not mean, and so you don't have to put the people all into the alcoholic area. So that this is also very dangerous in my eyes for creating these people a social stigmata.
Yes.
So that not alcoholics have chronic pancreatitis. And the other two most common reasons is the hereditary. This means the genetic predisposition of chronic pancreatitis, and the idiopathic. So we actually do not know why the patients do develop chronic pancreatitis.
What are the difference in clinical appearance of acute and chronic pancreatitis?
Actually, the first half of the patients come to your emergency room are both the same. It's pain. It's abdominal pain, starting the abdomen, also radiating to the back, and this is some kind of often unbearable pain. So this is what they have both in common. And chronic pancreatitis still can go on with additionally, since in chronic pancreatitis we do have got the development of inflammatory mass tumor formations in the pancreatic head usually, and when you have some kind of an inflammatory tumor, this can close the pancreatic duct but can also close the bile duct. That's the reason why the people often present with jaundice there. So that's one of the symptoms. And of course, since the chronic pancreatitis is affecting the entire organ, in chronic pancreatitis the people have got endocrine and exocrine function insufficiency. This means the patients do develop diabetes or have fatty stools since they cannot digest very well since the loss of the enzymes, which is one of the most important tasks of the pancreas to produce that enzymes.
Yes. What in terms of treatment can you do? In treating pancreatitis, it's always a question, should the surgery be applied or not? When is the right time? I think that it has been a dilemma for ages. So where are we now with the treatment of chronic pancreatitis?
Actually, at the moment, we are quite straightforward because we have 3 randomized controlled trials who demonstrated that surgery is superior to endoscopy treatment. But this does not mean that now everyone with chronic pancreatitis patients should undergo surgery. This is also wrong. So what we have in the community, in the pancreatitis community, have understood that we need a step-up approach. And the step-up approach is, first step is the medical treatment. So that once you have, first when you talk about chronic pancreatitis, you have to understand one thing. Chronic pancreatitis is a disease which you cannot get rid of. So all the therapy we give is actually taking care of the complications of the disease.
Yes. Making like some sort of remission.
Yes.
Yes.
But or getting, let's say, the symptoms lower, so the severity, but you will not have a causal therapy of the disease.
Yes.
And for that reasons, we have to the therapy of chronic pancreatitis is complication management. This is the therapy in chronic pancreatitis. Whereas in acute pancreatitis, you can get rid of the the disease, which we do not have in chronic pancreatitis. For that reason, the first is medical treatment with pain, digestive enzymes, etc., to insulin, etc., to have, let's say, somehow balance the situation. If this does not help, usually it does not help, it's over 90%, then the patients do need some endoscopic treatment usually, because they have got stones in the bile duct, they have in the pancreatic duct, they have got this inflammatory mass, they have pseudocysts, etc., etc. And these are all features complications of chronic pancreatitis, which you at the first hand can get rid in a good way with endoscopy treatment, with stenting, ERCP. And the problem is that once you have done this, then you have to repeat it all the time, because it is something which is not long-standing. In some patients it works, you do it once or the second time, and then the patients are fine for a quite long time. Then you are fine and you do not surgery. But if you do more than 3, 4, 5 ERCP stenting procedures, or even that your patient, although you do all that procedures, need more pain analgesia, especially opioids, then you are on the wrong track.
Yes.
And that's the reason why when the third approach, the step up, the third step, the surgery must come in. And when the surgery comes in, it is very important that you go to a center which is doing pancreatic surgery only. Yes. Because chronic pancreatitis surgery is much more complex than pancreatic cancer surgery. Yeah. Because usually when we do chronic pancreatitis surgeries, we try to avoid to do surgery which takes out the whole organ or certain parts of the organ. So what we usually try to do is organ preserving. Organ preserving, this is very important, organ preserving chronic pancreatitis surgery. And since every patient in chronic pancreatitis has got different complications, you are not only a surgeon in chronic pancreatitis, you are a tailor. Yes. So you have to make a nice tailor job for your patients. So because there is no the chronic pancreatitis surgical approach. There are several ones, and sometimes you have to combine different ones, just according to your patient. Yes. And to do this, so you have to be experienced in pancreatic surgery.
Yes, for sure. In terms that you need to take out what should be taken out, but preserve as much as possible. Yes. Of the tissue. Yes. And then what about the surgery? What are the surgical procedures that you apply for chronic pancreatitis? Especially in terms of, is it possible to solve the problem with minimally invasive surgical procedures, or is it like open, big surgery, let's say in these words? What about the surgery treatment?
There are nowadays more and more the laparoscopic and robotic also procedures coming up also for chronic pancreatitis surgery, especially regarding drainage of pancreatic cysts, or when you have a stone in the pancreatic duct. The operation is actually very simple. So you just open the pancreas, the duct, so you do not resect anything. And since there's pressure on the pancreatic duct because the stone is closing that, then it opens like a book. And then you just have to put a jejunum on it, so to release the pancreatic content into the jejunum so that you get rid of the pressure. Yes. And this you can do in a laparoscopic or robotic way. But the more complex operations, especially in the pancreatic head, with enucleating the inflammatory mass, etc., is not an undangerous operation, since it is it's an endocrine organ, so it's well perfused with arteries and veins and etc. And during the process of inflammation, it is even more, so it can cause a lot of bleeding. And for that reason, the domain of what all happens in the pancreatic head remains under the control of open surgery, actually. Yes. And there again, we do not the Whipple's procedure. This means we do not take out the duodenum, the pancreas head, the bile duct, and so on. We try to get rid only from the portions of the pancreatic head which are inflamed and which have caused problems for the patient. And so this is some kind of a combination of a resection and drainage operation.
Yeah, so this explains why it is important for a patient to come to an experienced and specialized center, because you never know which direction will treatment go. I would like to ask you also one thing that I think that usually worries patients. Is chronic pancreatitis the risk factor for developing a pancreatic cancer?
It is always a debate, but it's actually a neglected one, because the chance to get pancreatic cancer by chronic pancreatitis is less than 5%. So, and in my experience, I've faced 2 patients actually, and And in my time in Germany, we did a lot of chronic pancreatitis surgery. So we saw a lot of chronic pancreatitis patients, especially hereditary, because in this category, this is the only situation where we do know when you have some certain mutations that your risk to get cancer is much higher.
Yes.
But this is only in hereditary, and the hereditary chronic pancreatitis patients are a few etiological group, a small etiological group of the entire chronic pancreatitis patients. So for that reason, of course, there's a risk, but this risk is not so high that you should make your patients crazy that they will get cancer.
Yes, of course.
Sometimes surgeons use this as some kind of threat to push them to surgery.
Yes.
This is not correct.
Wrong.
This is not correct.
Yes. And since we mentioned pancreatic cancer, I think that it is the second topic concerning pancreas that is really something worrying patients, especially since it is a very silent disease, most of the beginning of the developing of the disease. And then when the patient starts to feel some symptoms and come to the doctor, it usually is in the developed phase, going to a terminal phase, and it's too late, and then we don't have too much options in terms of treatment. What about treatment of pancreatic cancer? What does you do and your center?
Actually, you can put the patients with pancreatic cancer in 3 categories. When the person comes to you and has got pancreatic cancer, in a case of, unfortunately, around 50%, they come, this is the way what you have demonstrated, is that they demonstrate with pancreatic cancer and metastasis. So it's not a local problem anymore. So we have a systematic disease. In this situation, unfortunately, we can only give chemotherapy to the patients, but also here we have got huge developments. Although the patient has got liver metastasis and pancreatic cancer, let's say when I started my career about 25 years ago with pancreatic cancer research, these patients died 3, 6, 9 months after diagnosis. Now they can even live up to 2-3 years. So it has changed. So that means we cannot still cure the patient when they are in a metastatic state, but with modern oncological therapy regimes, we can offer them a longer life after the diagnosis. So this is something which also has developed very well. Regarding me, especially as a surgeon, to get rid of pancreatic cancer, the most important thing is that you get rid of the tumor. So if you can't do that, you will not be able to cure the patient. And then you have got 2 categories still left. And the first category is the primary local resectable pancreatic cancer. This means there's a tumor in the pancreas. You have in the head or tail, whatever, without having any contact to vascular formations. So you have got not infiltrations of any vessels. So you can go upfront surgery, do the resection, and then the patient get adjuvant chemotherapy. And in this group, with the last figures we have, they can reach up to 51% 5-year overall survival.
That's a great,
this is amazing. Great statistic. This is amazing. Yeah, this is amazing.
Absolutely.
And then there's another group, the third group. These are the borderline or locally advanced pancreatic cancer. This means we have got cancer, but this cancer remains still only in pancreas, but has infiltrated surrounding arteries and nerves. And according veins. And according to the vascular, which infiltrates, it's more arteries or it's more the vein, we do pre-treatment. Pre-treatment means this neoadjuvant treatment, and with this neoadjuvant treatment, chemotherapy, usually we can get the tumor load down.
Yes, to be smaller.
This is not the most important thing, but the most important thing is more that the tissue around, the cancer tissue around the vessels just goes back. So that we have a line.
That you're safe.
That we have a line to go for surgery, and even in these situations, create an R0 resection, meaning no tumor remaining visible and also not visible under the microscope. So this is actually the golden task of every surgery. And in some kinds, when you have got involved the arteries in a higher way, we have got new data, which is also very compromising, that when you start to doing them with chemotherapy and radiotherapy, prior to the operation, that it is really impossible to predict what can you do with that pre-treatment, because we've got a lot of patients, and a lot of patients come to us where they were just mentioned in a couple of centers as unresectable. But in pancreatic cancer, you do not know this. Yes. Because when you do this pre-treatment and you've got a complete engulfment of the vessels, when you first see that picture, you would say, okay, the patient is lost.
Yes.
No? But the problem is, pancreatic cancer has a special feature. Pancreatic cancer, the cancer as such, is a cancer with full of stroma. Mm-hmm. And within the stroma, so the scar tissue, you've got islets of cancer cell cluster formation. And these cancer cell cluster formations, they can vanish during the chemotherapy. Yes. Or neoadjuvant chemoradiotherapy. But when you see on the CT scan, you still sometimes see it's the same.
Yes.
But how can you get rid of a scar tissue by chemotherapy? You cannot.
Yes.
Okay. And that's the reason why in this situation, we have to open the patient, explore especially these places around the vessels, and then take out some samples, frozen sections, send them during the operation to the pathology. And when the pathologists tell you this is only scar tissue, there's no cancer left, then you can go
straight.
And
yes.
Here in this situation, we made a huge experience with patients. Really, I mean, 10 years ago, I would say, when someone would have told me that I would be able to resect these patients, I would have said, I mean, you are crazy. Yeah? It's impossible to resect such. Yes. But we can do this now. And this is not the situation that I am now the biggest surgeon on earth. No, that's not the case. Of course, you have to be experienced, but the chemotherapy colleagues, the oncologists, the radiotherapy colleagues, the radio-oncology colleagues, they are helping me to do my job, yes. which we could not do 25 years ago. And for that reason, so we have huge developments, and we can reach in a lot of patients these R0 resections, which we could not do before.
Yeah, so we come to the beginning, why it's important to be in the center and in the multidisciplinary team who will take care of the disease incomplete. Since you're mentioning robotic surgery and you're doing robotic surgery, what do you think about the future of surgery in terms of robotic surgery? Do you think that it will replace laparoscopy, open surgical procedures, or that can happen never?
So you're asking me, I will be honest, or? I mean, look, robotic surgery is fine. I love to do robotic surgery.
Yes.
Because it's also fun, you know? I mean, yes. Everyone, when you do your job, it should
yes.
make also fun also.
Yes.
So for you, it makes also fun to do that job because it's more fine, and with the small steps, it's very good. But there's only one big but. When you compare at the end, especially oncological surgery, what is for you important? For you, it's not important that you have a scar which is like this or like this. Mm-hmm. Okay. And it is also not so important whether you go 3 days earlier to home mm-hmm. after the operation, because this also makes,
yes.
it's not of importance.
It's all the same.
Also makes no sense when you have suffered less pain during the first 3 days. Mm-hmm. What makes sense is two things. The overall survival, this means, does a surgical procedure affect my overall survival after an oncological disease, or does it affect the recurrence of the disease? So if you're doing, maybe sometimes would say, I do with robotic more radically, that's the reason why the tumor does not come back.
Yes.
This is not true. So there are no studies in the entire world, especially also starting with colorectal surgery, because in colorectal cancer, there where the robotic and laparoscopic surgery is done much more than liver and pancreas surgery, which I do. There is any evidence till now that you do better with oncological purpose after robotic or laparoscopic surgery. There's no evidence.
Yes.
The only thing is you have, let's say, cosmetical better mm-hmm. aspect. You have got less pain, you go earlier home, but that's it. So it's not that you do better surgery.
Yes.
Okay. This is very important to understand.
So everything has its place.
Yes.
And will have its place in the future. And now at the very end, I would like to to go back to the beginning and to ask you, you are talking about your experience that some patients which were inoperable 10 years ago now are surviving and living much longer. Do you have some cases from experience with, for example, these kind of patients and their survival rate?
First of all, to answer your question, it's important that you and also the audience understand, to make something impossible possible, you need a team. Yes. So you need, it's not only an experienced pancreatic surgeon, you need also the oncology, radio-oncology, you need interventional radiology, a gastroenterology, a good ICU unit, and a good nursing facility where the people are taking care of the patients and do recognize early complications at the early stage. So this is extremely important. So if you do not have some kind of these circumstances, you cannot do extended pancreatic surgery. It's impossible. So the surgeon is only one part of this. Okay. Of course, we are not unimportant, but we are only one part.
But you're quite honest.
Yeah, but that's it.
Yes,
that's
and modest, I would say.
Yeah. Regarding patients, I would say there are a couple of patients which come into my mind. There's also patients who even from France once. The patient was treated actually over a year with chemotherapy, which is not normal because they thought the patient has got liver metastasis. And then they approached me, and then I looked to the scans, and I was actually very surprised because I said, why do you get so much chemotherapy? Because you do not have any liver metastasis. Because this were only just hemangiomas.
Oh my
and we proved that also with biopsy. And then suddenly the patient became resectable. And now is living now over 2 years and has got no recurrence. So it's completely game changer. But to recognize again this situation, you have to see that all the time. Yes. So when you see every day pancreas and you see every day the liver, then it makes the difference.
Yes.
And also in the patient which I have just operated last week ago, this is an old lady. She was recognized with pancreatic body cancer, and the body is always a critical part because at the body, at the center of the pancreas, all the vessels in the front and the back are all coming together, and it infiltrated 2 big vessels. So the SMA, this is the artery which supplies all the intestine, and also the portal vein, which actually takes all the blood from the intestine and supplies the liver. So very important vessels. And then what we did here in this situation, she was just discharged from 3 different, also big centers, not to have been able to do the surgery in this severe case. But again, in this situation, when you got this chemotherapy before the operation and also the radiation, which you also got, you cannot judge upon the CT scan. You have to judge upon the patient.
Yes.
We opened the patient, sanded all the sections from the vessels, all negative.
To the pathology, yes.
But we saw that the infiltration of the vessel which is supplying the liver was really infiltrated still. So we took out the part of this vessel, connected again together, but the artery which was involved before was clean. So for that reason we didn't have to touch this, but you cannot see this if you don't try. So, and what we actually do, and this is, I think, it's better maybe to demonstrate you how great we are and how different things we do, is I think it is very important that you do not give up early, that you fight for your patient and give patient a chance. Because we do have some weapons now, especially the pre-treatment options, which we did not have 20 to 25 years ago.
Yes.
And for that reason, so this is something which we should use, and we also have to learn by ourselves where are our limits.
Yes.
This is also very important.
Yes, that's very important. I thought to ask you what are the key factors to success, but you just gave me the answer why you and your center are that much successful in treating pancreatic cancer patients. Thank you so much for a beautiful conversation, for all the detailed information that you gave us, and I'm sure that we will talk again, because the science is developing every second, and we will probably have in a year new topics to discuss in the field of pancreas. But I also wish to see you in Belgrade.
Yes, would love to.
Thank you so much.
Thanks so much.
Kada sam razmišljala kako da najavim mog današnjeg gosta, prva pomisao su mi bile reči američkog pisca Williama Faulknera, koji je rekao da je sukob unutar ljudskog srca jedina stvar vredna pisanja. I pisanje jeste neraskidivi deo mog današnjeg gosta, a centar njegovog pisanja jeste upravo čovek i srce tog čoveka. Danas reč ima, na moje veliko zadovoljstvo, Marko Šelić. Marčelo, dobar dan, dobrodošao i hvala ti puno što si danas moj gost.
Hvala tebi na pozivu.
Kako si?
Najteže pitanje za početak, ja? Ali hvala ti na tome zato što mislim da je osim što je najteže, to je najvažnije pitanje. Mislim da sve ređe pitamo jedni i druge kako si, ali u smislu kako si zaista, ne ono usputno, desi kako nego. Pa rekao bih da sam generalno dobro, uzbuđeno, jer se bliži proslava 20-godišnjice od objavljivanja prvog albuma. I sad smo u bendi, ja u probama, u planovima i tako dalje. Život je sad prilično okupiran time, ali i lepo je.
Da.
Naravno, na svim drugim poljima, kad gledaš situaciju u društvu, to me ne čini ni malo, ni srećnim, ni spokojnim. I onda malo sad postoji taj disbalans između toga kako sam ja lično, privatno, i kako je moja zemlja. To nisu uopšte...
Isto osjećanje. Da, vidiš, potpuno si mi negde pročitao misli, jer ja negde kao lekar, za mene je pitanje kako si najvažnije. Mene u stvari to pitanje vodi ka dijagnozi. Za tebe i za tvoje pitanje... Ne. Ka dijagnozi u profesionalnom smislu. Ali za tebe isto, ako gledam tvoje pisanje i ono čime se ti baviš i taj centar koji je čovek i to kako mu je, šta mu je, zašto mu je tako, nekako čini mi se da isto razmišljamo kada je to pitanje negde kada se postavi, ali sve više ljudi to pitanje ne postavlja. Sad si ti opet rekao da se nalazimo i nekoj, mnogi od nas u diskrepanciji sa tim kako je nama lično, kako je u okolini. Kako da tu diskrepancu prevaziđemo? I da li je rešenje da se povučemo u sebe ili da pokušamo da, ne znam, saosećamo, da na neki drugi način posmatramo pojave?
Pa i tu isto postoji... diskrepanca, jer što reče moj najbolji drugar nedavno, jel ti primećuješ da je postalo nemoguće ubediti bilo koga u bilo šta, jer više snaga argumenta ne važi. Mi smo se nekako prećutno društveno dogovorili da ne raspravljamo argumentima, nego da raspravljamo samo svađanjem.
Da,
a s druge strane čitav poslednji album naš, ta Nojeva Varka, je upravo o tome čemu vodi ako se svi povučemo i ostavimo da ovo sve bude ovako. I zaključak te priče je da to nije dobro i ne samo što nije dobro, nego da prosto ako nisi flegma nećeš uspeti ni da postaneš. Dakle, ravnodušnost se ne može odlučiti. Prosto ako nisi ravnodušan, ti možeš da probaš da se skloniš u neki svoj mikrokosmos, ali poješće te iznutra činjenica da više ne radiš na korist. Ja mislim da je korisno boriti se za neke ideale i za bolje društvo, koliko ko od nas može. Ako si taj, neće biti spokoja u povlačenju.
Da, ali upravo tvoj album Nojeva Varka je meni i dao šlagvort da te pitam u vezi sa tim povlačenjem u sebe. Jer čini mi se da ljudi i dalje imaju to saosećanje, imaju empatiju, vide sve te društvene pojave u ovom sistemu gde su totalno pomerene vrednosti, ali nekako da bi sačuvali svoje mentalno i uopšte fizičko zdravlje, biraju da se povuku u sebe. Kako ti na to gledaš i kako ti na kraju krajeva čuvaš svoje mentalno zdravlje u ovom sistemu?
Da, pa meni se čini da su za to masovno povlačenje, masovnu emigraciju u sebe zaslužna dva ekstremna razloga, rekao bih tako. Jedan je preosetljivost, a drugi je neosetljivost. Dakle, jedni se povlače zato što zaista nisu nabaždareni na, ja bih rekao, osnovnu empatiju sa drugima i mogu s lakoćom da proglase da ih to sve ne zanima. Ali poznajem mnoge ljude koji su to povlačenje preduzeli zato što su preosetljivi na društvene nepravde, na sve, i osjećaju se bespomoćno.
Da, mislim da je to glavno.
Da, a to je strašno stanje duha, nepodnošljivo. Dakle, da ti sad možeš biti samo pasivni posmatrač nekih baš onako kolosalnih nepravdi. A imaš sad treću kategoriju ljudi, otprilike svi mi koji se još batrgamo i pokušavamo da nekako u smislu otvorimo stvarnost. Ja bih rekao da je važno za mentalnu higijenu, i neću reći sad ništa epohalno, važno je da za šta god se boriš i u šta god da veruješ, to ne bude baš svakodnevno. Nego da prosto imaš neke malene periode, može to biti samo 2 dana, ne moraš nikud ni da otputuješ. Prosto sediš s ljudima koje voliš i radiš nešto drugo što voliš. Dakle, isključiti se iz događaja nakratko da bi se energija napunila. I to, biti okružen ljudima koji ti prijaju, kojima ti prijaš, imati neke hobije. Znaš, sve te sad, da ne zvučim kao motivacioni govornici, oni su u stvari uvek bili u pravu, samo preteruju.
Da, u ponavljanju.
Samo preteruju ponavljanjem, tako je, ali ništa od tih definicija nije suštinski netačna ni jedna, niti tu ima nešto, Bog zna šta novo da se izmisli. To je prosto tako. Dakle, dozvoli sebi da predahneš ponekad, pa onda nazad u kolotečinu.
Ali evo, pre nego što se vratimo nazad u kolotečinu, koji je tvoj hobi i kako ti predahneš?
Pa znaš šta, ja sam do duše sklon da od svojih hobija napravim profesiju. Tako je bilo od malena, mislim.
Onda si ti srećan čovjek.
Ajde, recimo, hvala ti. Pa ne znam, recimo, ja sam u svet čitanja, a od čitanja sam također napravio profesiju, jer to mi piše na diplomi, profesor maternjeg jezika i književnosti, ali zapravo u čitanje sam ušao putem stripova, a ne putem knjiga. Knjige su došle malo kasnije, prvo su tu bili stripovi, i onda hobi mi je bilo crtanje. Crtao sam stripove.
Da, to sam čula da imaš neviđen dar. Iako verujem da puno ljudi to ne zna.
Hvala, ljubazna si, ali sigurno nije baš neviđen čim ljudi to ne znaju. Dozvolio bi ja da se to vidi.
Možda ti nisi, pa to sad ne znam.
Ne, ja sam procenio kao klinac da eto, privlačilo me pisanje, privlačilo me crtanje. Učinilo mi se da treba da odaberem čemu ću se posvetim i odabrao sam svet reči, jel? Nastavio sam pomalo da crtkam i to nekad uradim i danas. To je verovatno to izgleda bolje nego u slučaju nekoga ko se nikad nije bavio time. Ali ne mislim da sam tu nešto naročito mogao da napravim. Međutim, nastavio sam da budem obožavalac stripova i onda se dogodilo to onako sudbinski, zanimljivo neko bi rekao, da me ono čime se bavim dovelo u strip redakciju u Veseli četvrtak gde sam 15 godina radio kao urednik Dilana Doga i sad pomalo neke edicije. Povukao sam se, ali ne sasvim. Ali eto, kao napustiš crtanje zbog jezika i pisanja, a onda te jezik i pisanje dovedu u
vrati tamo gde si počeo.
Tako da eto, van toga, dakle, tu je ljubav prema figuricama vezanim za pop kulturu. I mislim da je to u stvari trauma iz detinjstva. Znaš, kod 90-ih sve ono siromaštvo i sankcije, embargo i svačiji ćale ide u Bugarsku s torbama. I onda smo mi tako, moja generacija, svi oni likovi iz crtača, sve te figurice, mogo si da odeš u tadašnju robnu kuću u Beograd i da patiš što tvoji to ne mogu da kupe.
Rasli smo u isto vreme.
I ja mislim da sam ja odlučio nekad tih godina, možda ne sasvim svesno, da ću se jednom osvetiti toj nemaštini i da ću pod stare dane kasnije da kupim svaku figuricu koja mi se sviđa, da stavim na policu i da je gledam u trenucima kad odmaram. Tako da eto, možda nekom i to možda posluži kao savjet, a možda je budalasto, ali meni se sviđa.
Ali vidiš, evo sad si rekao da se vraćaš, da se odužiš onome što si u detinjstvu sebi obećao. I negde znam da stalno govoriš da je tvoj kompas u stvari taj dečak u tebi kome se ti stalno vraćaš i koga ne želiš da razočaraš. Jel uspevaš, evo sad ovako iskreno, kad pogledaš retrospektivu, da li si ikada sebe razočarao pa se ponovo vratio na taj neki svoj put ili ne?
Ne na suštinski način. Ne na način, ako uzmemo da je tačno to što si sada spomenula, a ja stvarno verujem da su ta deca koje smo nekad bili, deca generalno vide svet, daleko čistije i jasnije. Mislim da nikad nisam uradio nešto što bi ozbiljno razočaralo kompas taj dečački, a naravno da postoje razne stvari i postojale su i nastavit će postoje koje ne uradiš baš najbolje, pa popraviš, pa ovako, ali ne govorim dakle tu o suštinskim greškama i suštinskim pokajanjima, govorimo o greškama u procesu ili prosto u življenju koje imaš kod svakoga.
Da, ali kako ostaneš onda dosledan? Jer nije lako. S druge strane, kad si bio dečak, nisi imao popularnost koju imaš sad. Nisi imao neku moć, reči, sve što sada imaš. Kako čovek da uspe da ostane dosledan sebi?
Pa tako što ostane dosledan sebi.
Da, vrlo jednostavno.
Naravno, ima tu raznih izazova i mislim da je, znaš kako, bilo šta u šta čvrsto veruješ sigurno će te dovesti u situaciju da nekad moraš nešto da istrpiš, da nekad moraš nečega da se odrekneš. Dakle, ako recimo za mene dosledno znači nemoj pisati tekstove za narodnjake, lupam, a svakako znači
bez obzira što bi ti donele korist.
Bez obzira što bi donele mnogo koristi, jer se razumiju, ti ljudi žive sjajno. Ja sam u nekoliko navrata imao prilike da čujem koje su cene tih tekstova i to je stvarno, to su onako sume koje obezbeđuju bezbrižnost, ja bih rekao, u finansijskom smislu prilično. Ali moja odluka je ta da čitav taj turbo folk talas je deo moje traume iz 90-ih, ove društvene. I kao što sam odlučio da nikad neću dati izjavu za Pink ili se pojaviti na Pinku, tako sam isto odlučio da nikad neću sarađivati s okupatorom u tom smislu.
Da, ali opet se vraćaš na dečaka.
Pa da, prosto, ali stvarno šta su izazovi? Izazovi su da kad radiš nešto što je uslovno rečeno alternativno u odnosu na taj mainstream, naravno da će postojati meseci kad finansijski stojiš jako tanko i naravno da bi tad bilo vrlo spasonosno da, ne znam, napišeš 5-6 tekstova nekih, kao uzmeš pričaju ljudi da to tako biva, jel? Ali moja je čvrsta rešenost da kad dođu ti dani to istrpim i ne pokleknem, jer znam da bi posle, možda to niko ne bi ni znao, ali ti znaš. Ti možeš potpišeš pseudonimom nekakvim i kao nisi to ti, sve okej, ali izneveravanje sebe ostaje. Nije to toliko pitanje šta će reći drugi, nego šta će ti reći odraz u ogledalu. Tako da...
Da, koji je najvažniji. Negde ne bi bio bezbrižan sam sa sobom, a to u suštini nema cenu.
Tako da u suštini kažem, doslednost je u stvari pitanje, naravno pod A, pitanje odluke, ali pod B, pitanje spremnosti da istrpiš kada ta tvoja doslednost dođe na nekakve ispite.
Da, ali ako imaš tu doslednost, ja duboko verujem da onda čuvaš i svoje zdravlje. Jer si sam sa sobom okej za svoj postupak ili za svoju odluku.
Pa meni se čini da to jeste bitan faktor. Kako se osjećaš kad legneš da spavaš? Da li, ne govorim naravno o brigama dnevnim koje nas more i tako dalje, ali suštinski da li si u miru sa sobom? Ako jesi, mnogo si sposobniji da se uhvatiš u koštac sa tim dnevnim problemima koji god bili.
Da, ali reci mi sad kako, pitala sam te kako stojiš sa dečakom u sebi, kako stojiš sa vožnjom?
Odlično.
Voziš auto?
Volim da se vozim, ali ne i da budem za volanom. Ja sam odmah, prvom prilikom sa 18 polagao vožnju i već sa 19 odlučio da odustanem.
Zašto?
Pa znaš kako kažu, ima budala u saobraćaju. To kad kažu misle na mene.
A šta se desilo?
Ja sam taj. Pa ne znam, nekako sam prosto osjetio da umem da budem glava u oblacima preko mere koja je dozvoljena ljudima za volanom. Ili se bar meni tako učinilo. Ja ću početi da razmišljam o rečenici, o stihu, o već nečemu i kažem ti, to su budale u saobraćaju, na njih se misli tom frazom. Oni prave probleme, oni prave zastoj, oni prave gužvu. Nikad nisam, ili ono što kažu kao, moraš da osjetiš da si jedno s autom, nisam osjetio tako. Tako da moje interesovanje za automobile postoji samo ukoliko se transformišu u džinovske robote u crtaču ili filmu.
Ali čega se u životu plašiš? I da li postoji nešto što je tvoj strah ili nemaš strahove?
Pa meni se čini da je dosta budalasto reći da nemaš strahove. Baš bi volio da sretnem osobu koja se tako izjašnjava. jer bi bio siguran da prosto nije dobro razmislio ili da laže.
Da, ili da.
Čak meni se čini da sve ono što nazivamo hrabrošću nužno dolazi iz straha, iz svesti da si uplašen od neke vrlo realne pretnje, ali da sada moraš da preduzmeš taj čin zvani hrabrost, jer će u suprotnom nastati nešto još gore. O tome šta su sve moji strahovi treba nam mnogo više nego što traje ova emisija. Čak mislim da čitav sledeći album će imati kao jednu od stožernih tema i strahove. Ali recimo na nivou ovoga što smo do sada pričali, eto, strah od izneveravanja sebe je takođe deo odluke zašto si dosledan.
To je tačno.
Na primjer, a veruj mi, to je samo vrh ledenog brega. Ne bih rekao nikad o sebi da sam plašljiva osoba. To je sad kao drugi suprotan ekstrem. Ali definitivno da, postoje strahovi i možda je vožnja jedan od njih. Čak sam proganjala me dugo noćna mora pogibije u saobraćajnoj nesreći, koja nije uzrokovana ničim što mi se zapravo dogodilo. Dakle, ne znam zašto mi se to pojavilo.
Bio neki tvoj strah, da.
Tek eto, i možda i to uticalo na tu odluku. Ali zanimljiva stvar, kad se godinama kasnije zaista dogodila saobraćajna nesreća koja je mogla da ispadne na daleko bilo, srećom nije, samo sam slomio rame, nisam bio za volanom jer nisam bio nikad za volanom od 19. Zanimljivo, tada, odnosno posle toga, taj san se više nikad nije vratio. I kao...
Ali vidiš, to je interesantno. To je prosto neki način kako si ti prošao kroz to.
Da, kao... Nisam ni sad siguran kako to da razumem. Popričat ću sa svojim drugaricama koji su psihoterapeutkinje, pa možda one imaju odgovor. Ali zaista intenzivno sam od detinjstva, a dakle ničim to nije bilo izazvano, sanjao saobraćajnu nesreću u kojoj ginem, a onda se dogodila za malo, ali kao sve je ispalo okej i san je nestao.
To je najvažnije da je nestao. Ali evo, za kraj moram da te pitam da mi kažeš koja je poslednja dobra knjiga ili dobar strip koji si pročitao i da negde bude preporuka svima nama.
Ono što sada čitam je Bone. To je jedan onako baš klasik 9. umetnosti koji trenutno ga objavljuje Čarobna knjiga. Izdanje je jako lepo. Objavili su 3 toma do sada. Ako se ne varam, bit će ih ukupno 5 i ja mislim da će to verovatno sad za sajam da se i dovrši, tako da će ljudi moći da kupe i komplet. I mislim da je to štivo koje zaista podjednako može da se svidi i klincima i nama matoraćima. A ovo izdanje je pritom i u koloru. Bon, koliko ja znam, nije originalno bio u boji, ali ovo izdanje je priređeno u boji, tako da eto, još jedan razlog više. A što se tiče književnosti, čitam intenzivno mog dragog prijatelja Marka Tomaša, koji uskoro, ako se ne varam, za Buku objavljuje novi roman. Ljudi ga prvenstveno znaju kao pesnika, ali evo Mareta i u prozi, ovo mu je već drugi. Tako da malo sam se vratio na staro gradivo pre nego što pročitam taj novi roman jer mi ga je poslao. I eto, baš sam sad ushićen oko toga. Jako je lepo kad se ljudi tako poznaju, povežu međusobno i onda imaš prilike da čitaš pre nego što izađe.
Jeste, i praviš neki svoj krug isto.
Tako da.
Znaš šta, ja se radujem proslavi ovih 20 godina karijere, ali isto tako se radujem svemu što ćeš ti nama novo prirediti, tako da ja tebe već vidim ponovo kao našeg gosta. Nadam se da ti priča o zdravlju nije bila mnogo traumatična. Hvala ti puno.
Hvala tebi.
Mi smo stigli do kraja još jedne naše zdrave...